Expanded Endonasal Endoscopy for a giant Tuberculum Sella meningioma, the 10Ds. A 46-year lady presented with decreased vision on both sides for 1 year and headache for 3 months. On examination of vision, there were just hand movements close to the face. Contrast MRI showed a densely enhancing extraaxial mass lesion suggestive of meningioma of maximum dimension 4 cm centered on the tuberculum with anterior dural enhancement up to the planum sphenoidal. The tumor base was narrow in the coronal section with no lateral dural tail. In CT angiography, the tumor was very close to the ACOM complex with no encasement of vessels. Rationale: surgical excision is the standard of care. Endonasal approach obviates handling of optic pathway. Despite being large, there is only anterior but no lateral dural tail. Though close to ACOM complex, there is no vascular encasement. The patient was supine with the head end elevated 30 degrees and fixed using a skull clamp in mild neck extension. 4K endoscope system with 0 and 30 degree scopes, navigation and high-speed drill were used. The 10 Ds of this procedure include delineation of vascularized flap, drilling of skull base, durotomy, devascularization, decompression, detachment, dissection, delivery of tumor, disengagement of optic canal and design of skull base reconstruction. The procedure was started with a 0 degree scope. The nasal cavities were decongested with adrenaline-soaked sponges. The right middle turbinate was coagulated at the base and excised. The vascularized nasoseptal flap was marked using hook monopolar cautery. The superior incision was inferior to sphenoid ostium, avoiding injury to the olfactory region. The postero-inferior incision was made along the border of the septum and the nasal floor. Both the incisions were joined vertically. The flap was dissected off the osseo-cartilaginous septum and placed in the oropharynx. Posterior septectomy was performed, preserving the bone graft for reconstruction. Nasoseptal mucosa along the corridor was cleared and hemostasis was achieved using a coablator. A wide sphenoidotomy and posterior ethmoidectomy incorporating superior turbinates were performed using rongers and a high-speed drill. The sphenoid's rostrum, keel and septa need to be removed for good instrument maneuverability and to prevent dead space under the flap. The mucosa of the sinuses was stripped off completely to avoid postoperative secondary mucocele. Under CT angiography and MRI navigation guidance, the area of the tuberculum and planum under the tumor was drilled out with the medial opticocarotid recess and the carotids as the lateral limit. After ensuring adequate binostril exposure, the dura was incised with incremental devascularization and decompression initiated in the midline base of the tumor using a coablator, curettes, aspirator, through-cutting forceps and knife depending on the consistency. Henceforth, a 30 degree scope was kept on the floor of the right nostril angulated upwards and fixed on a rigid holder along with an irrigation system while suction was positioned cranial to the scope and other instruments were inserted through the left nostril. After coring the central portion, the lateral and anterior parts of the tumor were gently disconnected from the surrounding dura. As the tumor was too fibrous to undergo extensive early internal decompression, dissection was started meticulously from the postero-inferior pole in the extra-arachnoidal plane using bimanual techniques. The dissected tumor fragments were intermittently excised piecemeal to clear the way towards exposing optic chiasm and A1 segments of anterior cerebral artery. Care was taken to protect the perforators. Only after exposing A1 segments, the dissection was extended circumferentially on either side. Aided by the optics of rotating the 30-degree scope, the tumor was gently rolled towards the center with angled instruments, keeping suction tip as a counter traction to avert any neurovascular injury. The arachnoid over the pituitary stalk was preserved along with hypophyseal vessels. Dissection was the most prolonged phase of the surgery and was carried out patiently with micro-rolling maneuvers, keeping the arachnoid layer over the vessels intact and bit by bit tumor removal, progressively making the tumor smaller and smaller. The delivery of the tumor was carried out incrementally so that further deeper visualization could confirm any residual attachment. The ACOM complex was the last to come into view as it was directly posterior to the tumor and intimately associated with the capsule. Protecting the ACOM complex with a long curved flat dissector, the capsule was gently peeled away. Once the capsule was confirmed to be free all around, it was gently mobilized out. The last remaining attachment to the lateral tuberculum dura was separated carefully, leaving no residue. The dural attachment was coagulated anterolaterally. Tumors in both optic canals were scooped out using angled visualization. In the end, both optic nerves, optic chiasm, anterior circulation vessels, and pituitary stalk were seen clearly. ICG angiography revealed intact subchiasmatic and hypophyseal vessels. Skull base reconstruction was done in a multi-layer. An appropriate size fat lobule and fascia lata harvested from the patient's thigh were placed one after the other in the operative cavity with the bone graft forming a gasket seal and covered by the vascularized nasoseptal flap. Fibrin glue was applied over the top and a piece of absorbable gelatin sponge reinforced the construct. Patient's vision improved to counting fingers. The histopathology was meningothelial meningioma WHO grade 1. MRI imaging revealed no residual or recurrence till 1 year follow-up. Giant tuberculum cell meningioma is surgically challenging because of deep-seated location and proximity to critical neurovascular structures. The endonasal versus transcranial debate is still not settled. The visual outcome is possibly superior with endonasal route, but CSF leak is still of concern. The 10D steps as elucidated here are safe and effective during endonasal endoscopy for even a giant tuberculum cell meningioma without lateral dural tail.